Thanks. So we thought we'd follow up with thinking about DXA reporting and DXA quality, about really looking at it from the other point of view. So for someone like myself, a rheumatologist with a special interest in metabolic bone disease, or endocrinologists, I will just mention that they do bone disease as well. How am I using that DXA report in my clinic, and what influence is it having over my management? And I think it's really key here to think about how we manage patients with osteoporosis. So, you know, the saying goes, no man is an island, and we certainly can't do this on our own. Those of us sat in bone clinics, the osteoporosis doctors, are surrounded by all these other people, orthopedics, obviously the patient, radiographers or technicians, the GP, there's operational support in running our services, radiologists, nurse specialists are key. And up the top left there, I put the Royal Osteoporosis Society, as their information that we use in clinics is also key for managing our patients. So there's a lot of people who input into this, and when I'm teaching our radiographers locally, I really try to impress on them that what they do with the DXA scan is absolutely essential and pivotal to what treatment decisions I'm going to make and the discussions I'll have with the patient. So I'm just going to go through the different ways that I'm using the DXA scan and the report when I'm seeing patients. So the first one's really obvious. Osteoporosis has a T-score definition, and this is really helpful. So we're going to look at the T-scores, and we're going to decide if the patient has normal bone density, osteopenia, osteoporosis, or this diagnosis of either established or severe osteoporosis, depending which publications you look at, where the T-score is less than -2.5 and the patient has had a fracture, which comes back to what I was talking about earlier about how that increases your fracture risk. So we've made a diagnosis with our DXA. The second thing we're going to use it is in our fracture risk calculation. So I've mentioned FRAX quite a lot earlier, but this is to show you what this looks like. So this is a fracture risk calculation tool. It's going to give me a 10-year fracture risk of somebody's major osteoporotic fracture risk and their hip fracture risk. So I select the country, and then I use this questionnaire, and I'm going to select all these risk factors, and I can put in femoral neck BMD that you can see there and calculate. Now, many of you that may do this on the scanner, and that's really helpful, and that becomes part of the DXA report. Sometimes some services I'm aware of do it always in clinic, and sometimes I will redo it. So within my service, it's done on the radiographers put this all into the scanner, and this churns out the FRAX. But sometimes I will redo it in clinic because I've got a more detailed history. I might get some slightly different information for the patient, or there might be something. One common example would be whether you're really going to call a fracture a fragility fracture or not, how long ago it was, and therefore I might discuss with the patient what their fracture risk is if I include that as a risk, and what it is if I don't include that as a risk. But it's more accurate if I've included the bone density. And as we've seen already, the fracture risk calculation is going to influence my treatment choices. So we haven't gone through treatments in great detail, but the good news is that we have a lot of approved treatments for osteoporosis, many more than a few years ago, with the advent of romosozumab and abaloparatide in recent years. So we have choice, and we're making that treatment choice on as I mentioned earlier, on a number of issues. But can I get an osteoanabolic for my patient? That's my number one thing. And then if I can, which one? And otherwise, which one of these treatment choices would be best for my patient? And it may be that, as I mentioned, in the case of teriparatide, I need a certain T-score, or it may be that in the case of abaloparatide, I need a certain fracture risk. But DXAs don't just tell us bone density, and they sometimes can be helpful for telling us other things. So here's an example of a bone density scan. And when we look at the image, we might think that L4 looks a little bit short. As we go down, our lumbar vertebrae should get taller, and that one's shorter. When we look at our T-score, the average T-score is -2.9. In L1, 2 and 3, we're in the -3s, but L4 is in -1.9. Now, this should have been excluded from study, but it wasn't on the day. And I looked at this in clinic, and this is a vertebral fracture. So we can get information from DXA that is going to change our management practices. What about other tools? So there are other things we can start to use DXA for. So vertebral fracture assessments can be really helpful. There are guidelines around who should have those, and I'm aware of many services, mine included, that struggle to incorporate vertebral fracture assessments. You may be doing some long femur views. These are increasingly helpful if we're possibly monitoring for atypical femoral fractures. And the International Society for Clinical Densitometry has some guidelines over who should have them, depending on how long treatment's been on. And some of you may be using trabecular bone score, TBS, to give an idea of bone quality as part of DXA. So those are other ways that DXAs can help us in our management. And later on, we're going to hear about AI, which I think is going to be an absolutely fascinating sphere. And I expect there are all sorts of ways that our imaging technology can help us that we're not using already. A classic way that we've used DXA scans and DXA reporting is to think about changes in bone density and response to treatment. So just to remind us that bone density is an excellent predictor of fracture. This is some really old data from 1996, published in the BMJ. And it's looking at bone density, blood pressure and cholesterol as predictors of other disease things. So here, bone density predicting hip fracture, blood pressure predicting stroke, and cholesterol predicting myocardial infarction. For the blood pressure and cholesterol, as you go across the quartiles, these are getting higher. For the bone density, it's getting lower. Now, we're never in doubt that cholesterol predicts an MI and that blood pressures would predict strokes. But look here, bone density works just as well as a predictor of hip fracture as blood pressure does of stroke. So we are looking for changes in bone density that will tell us that that will reduce the patient's risk of a fracture. And that's another way that is important for us to see if we're monitoring a treatment. So that brings me on to the idea of what is a treatment failure. And this is a bit of a perennial problem in the clinic. How do I know that my treatment is working? This opinion piece by Diaz-Perez, which is now over 10 years old, tried to address what treatment failure is. We know that there's no treatment in osteoporosis that is going to prevent every single fracture. So they came up with this definition. Firstly, 2 or more incident fractures during treatment. So you're kind of allowed potentially to have 1 fracture on treatment, but if you have 2, that would be considered a failure of the treatment. If you're measuring bone turnover markers, and they're not suppressed, then that means your treatment isn't working. And some services will do that, although it's not routinely used in the UK to monitor therapy. And if bone density continues to decrease despite treatment. Now, this definition of treatment failure might be a little bit outdated as we come into the sort of osteoanabolics first era, but I think it's still worth bearing in mind as a helpful guide to think. There have been changes in general in when we monitor bone density and how we do that. Very much more now. We're not routinely requesting bone density scans every 2 to 3 years or even sometimes previously every year, to monitor treatment or monitor patients off treatment. We're much more moving in the clinical service to monitoring bone density at key time points. So what those would be at the end of a treatment course. So when you've prescribed a course of treatment and then you want to look at it, or if a patient has a fracture on treatment. And I think in contrast with this Diaz-Perez paper, we would definitely reassess if the patient's had a fracture and they've been on treatment a reasonable amount of time. If they've literally just been on treatment, you probably wouldn't repeat the bone density scan. And the end of a treatment course is likely to be 5 years of an oral bisphosphonate, 3 years of intravenous zoledronate, possibly at 5 years or 10 years of denosumab, or potentially at the end of a course of osteoanabolic, which is 12 months for romosozumab, 18 months for abaloparatide, and 2 years for teriparatide. So we should be doing less monitoring bone density scans, and this allows us to free up our clinics. So that's a bit of a whistle-stop tour, but those are the key ways that we use DXA as part of our treatment decisions. We know that bone density is not the only thing that factors into our fracture risk, and as I said right at the beginning of the afternoon, we know that a lot of fragility fractures happen in patients who do not have osteoporosis by DXA criteria. But DXA remains a key, integral part of our treatment decisions and our ability to give our patients the best treatment that's available for them. So I hope for those of you on the kind of scanning and reporting end, that might be useful to think about how we in the clinic use the DXA report. And I'm really happy to look forward, in fact, to having some discussion about this. Thank you.